So payment systems for gynecologic surgery are really in rapid transition right now. What the gynecologic surgeon needs to know for now is how we're getting paid in 2014. And that is based on the RBRVS system. That's a system where the work and the practice expense and the malpractice pieces come together into what's called an RVU, or a relative value unit. Those units, though, for us surgeons seem a little bit discordant, but they encompass not only the work that we do in surgery, but also the work we do before and after for the 90-day global period. And unfortunately, the more hospital visits, the more encounters we have with a patient after surgery, the more RVUs we get. So there's a disconnect for us who do minimally invasive surgery. It looks like we're not being valued properly for what we do. But when you look at the time that it takes us to take care of these patients, clearly they're not in the hospital as long and the payment is lower. In order to get paid properly, we have to marry that CPT code, or the procedure code, to the correct diagnosis codes. And that's where our challenge is going to be starting in October of 2014, the conversion from ICD-9 to ICD-10, which is a much more granular system for defining the reason why we did the surgery. And there's a lot of fear out there that payers are going to deny claims because we didn't switch properly to ICD-10. The American College of OB/GYN has actually put out some very easy conversion charts. They're available at the ACOG bookstore. They're laminated charts that make it very simple to go from ICD-9 to ICD-10. And I would encourage everyone to get a hold of one of those. They're inexpensive, and it will make your life so much easier and ensure, because if ACOG says this is a proper crosswalk, I think it's clear that the payers better accept it as a good crosswalk. So for 2014, I think that's our system, but as we're looking for the new systems that are coming into play 2015 and beyond, we're looking at what's called value-based purchasing, certainly in the Medicare system, but also a lot of private payers are moving in that direction. And that means we're going to have to start holding our own feet to the fire about the outcomes of the surgery that we do, the cost of the intervention. If you look at episode treatment groups, ETGs, for example, there might be one that says abnormal bleeding, and the entire cost of the encounter would be included in the ding to us for what it costs us to take care of patients. The ringers there are those of us who have really referral practices where we're only seeing those patients who need surgery. We're going to have to be very, very careful that risk adjustment is provided in those systems. I'm certainly working very, very hard to ensure that those people who do high volume, high risk surgery don't get removed from panels because it looks like we're high cost. We're high cost because we're doing those things that no one else can do. But those are things we need to be aware of. We need to be quite aware in our own region about the big payers and how they are converting. We need to be aware of accountable care organizations and contracting with them, and be really careful about those contracts and ensure that attributable risk is accounted for, make sure that outcomes are accounted for, that we are truly delivering the value to these systems by being high volume, high quality surgeons.